this meeting. The lively discussions only show that we do need to meet and discuss issues which are relevant to renal pathology. So muchas gracias. My learning objectives as shown here, I have nothing to disclose. I will talk about amyloid. I'm not sure whether I'll have time to finish the last points on my outline. I would like to begin with what amyloidosis is, and keep in mind please this image. On the left side you have a functional protein which is soluble, biologically functional, composed mostly of these corkscrew structures which represent alpha helix. Under certain conditions, the same protein, without changing its primary amino acid structure, can undergo conformational change as shown on your right side, and it gains different conformation as shown as these flat ribbons. And these flat ribbons represent the beta-pleated sheet structure. And this has several consequences. Not only the protein is non-functional, but it's also no longer soluble because it's hydrophobic, it's sticky, and moreover it exerts toxicity to other proteins. It's proteotoxic. It tends to recruit other proteins to acquire the same beta-pleated sheet conformation. It's sticky, it aggregates, and is resistant to degradation. And we all know that the term amyloid is essentially a misnomer because amyloid is all about proteins. Now, during the normal metabolism in the cells, proteins which are less than perfect are produced all the time, but there are mechanisms in place which take care of such imperfect proteins. And these mechanisms operate at the cellular level as proteasomes, shown here, as well as at the extracellular level as macrophages, for example, as shown here. Okay? And these mechanisms, protein control mechanisms, tend to capture these imperfect proteins, degrade them, and recycle them into the metabolic pool, and where the amino acids are reused for production of future proteins. So under normal circumstances, we are quite efficient recycles. But of course, you can imagine that if this system is overwhelmed or subjected to some kind of toxicity, then it's less capable of keeping under control this recycling process. Or, at the other hand, if the supply of these imperfect proteins is increased, such as increased concentration as happening in these conditions, where we have proteins which are intrinsically unstable, wild type but intrinsically unstable, or unstable owing to mutation, we may overwhelm the system such that recycling and complete degradation is no longer possible. There are also instances where incomplete proteolytic cleavage is involved. And with that, we have increased supply of misfolded proteins, which being sticky, they stick together, form protofibrils, and protofibrils further turn into fibrils. And only at this level, we can see them by Congo red stain, because the beta-pleated sheet has sites which bind Congo red stain, and they are fibrillary by electron microscopy. At this stage, the fibrils contain serum amyloid P component, apolipoprotein E, etc., which are thought to be fibril stabilizers, and we can use those as markers of amyloid by immunohistochemistry or proteomics. But important point to remember is the fact that the proteotoxicity begins already here before we can actually detect amyloid. So what we see, even at the very early stage, is essentially a tip of the iceberg, okay? So this is an urgency to try to detect amyloid as early as possible. There are many proteins which can undergo amyloidogenesis. Currently greater than 32 protein types, many more variants. The most important to us is to detect and diagnose those which are treatable versus those which are not treatable, and of course those where genetics is involved for the purposes of counseling and prognosis. This is an abbreviated table showing these various protein amyloidosis types. On the top are systemic amyloidosis, and they essentially all affect the kidneys. Of course, I will not talk about localized amyloidosis. Alzheimer's is one of them, but there are also other types, okay? So with that, let me just run through the most important types of systemic amyloidosis which can affect the kidney. And of course, AL, A stands for amyloid, L for light chain, amyloid derived from the immunoglobulin light chain. This image is a very characteristic of a patient with capillary fragility due to amyloid deposits. It is important that AL is the most common type of systemic amyloidosis in the developed world, about 85% of the cases, right? So what we see most commonly among these rare diseases is bound to be AL, but it is important to keep in mind that it's not 100%, okay? And by definition, AL is a consequence of a clonal proliferation of plasma cells, which produce monoclonal protein, also termed M component. And it is a systemic disease because this M component circulates in blood. And in the majority of patients, about 70%, there are renal symptoms with proteinuria and or nephrotic syndrome. Hence, it is up to us to detect these patients early because presentation with proteinuria usually prompts a kidney biopsy. Cardiac involvement is particularly deadly. Symptoms are less characteristic, and of course cardiac biopsies are not as readily done as kidney biopsy. And of course other organs, hepatomegaly, cardiopulmonary syndrome, peripheral neuropathy, and various other features. I want to show you the discuss briefly the concept of AL amyloid as an example of an M component related disease. Okay, so on the left side you have image what shows B-cell neoplasia, such as multiple myeloma, where you have a large clone such that the clinical manifestations are due to the clone itself. The patients have bony lesions, hypercalcemia, infections, systemic symptoms, as well as clinical manifestations due to the M protein. Most commonly, light chain nephropathy, hyperviscosity. But only about 10 to 15% of such patients will have light chain amyloidosis, and these patients tend to be at the lower spectrum of the tumor burden, okay? The great majority of patients with AL, okay, 85% at least, have what we refer to as M component related disease. We have a small clone such that clinically there is really no manifestations due to the clone. So there is the clinical suspicion may be difficult to arrive at, but yet 85% of patients with light chain amyloid will have this type of disease. Others which may be associated with light chain deposition disease, light chain proximal tubulopathy. So think about light chain amyloid as a disease associated with a small but dangerous clone. Okay, the light chains which are being produced, they have intrinsic instability, and they can be deadly, okay? But many times in the serum, the levels may be negligible or not detectable, even with the most updated laboratory testing. Serum-free light chains in particular may miss some small percent of these patients. Moreover, it comes to the point that we have to think about AL amyloidosis as most of the time being phenotypically different from multiple myeloma due to internal amyloidogenic light chain toxicity. And in terms of treatment, it's intuitive to assume that one should target this clone, right, which causes the clinically apparent disease. But the same approach is operational for the M component related disease. And the treatment is not any trivial treatment, it's the same heavy duty stuff. So diagnosis of the light chain amyloidosis is a very serious one, because what follows is a high-risk therapeutic intervention, okay? So please beware, make this diagnosis only when you are really sure, okay? And what happens is chemotherapy, autologous stem transplantation. Nowadays we have more targeted therapies with proteasome inhibitors, and these treatments are effective providing the diagnosis is made at the early stage of the disease, okay? And unfortunately, many patients are diagnosed at the stage when they are too frail to undergo this brutal therapy, which, however, can lead to durable responses. I am meeting with the patients as a part of amyloidosis support group, and there are patients who are living 10 years plus post-diagnosis of light chain amyloid. So keep in mind, okay? Now, we are switching gears, okay? You see here somebody with inflammatory arthropathy. This foot is supposed to show, I don't know whether you can see, some skin redness, a recipaloid rash, and this rather well-fed gentleman. And these images are all associated with AA amyloidosis. AA amyloidosis, where you have amyloid derived from serum amyloid A protein, which is being acute phase reactant, is upregulated during chronic inflammatory processes. You know that it's produced by the liver, and we have a systemic disease. And kidneys essentially affected in almost 100% of the patients, and other organs include liver, spleen, and GI tract. This is a typical image of the kidney, but beware of the fact that about 3% of patients with AA amyloidosis can have medullary deposits. Now, AA is the most prevalent type in the underdeveloped countries. Situation in the developed countries is markedly different between North America and Europe. In North America, the numbers of cases reported more recently has been declining. It may be due to improvements in treatment or decrease in reporting. Situation in Europe is different, and it's at least twice as common, but still in the third world, AA is more common than AA. It is important to keep in mind that there is a group of disorders where we may have familial AA amyloidosis, okay? And here we have mutations in the proteins which are handling inflammation as a part of an innate immune system, okay? And the best, some of them are monogenic, others are polygenic. The best known, at least in this part of the world, is familial Mediterranean fever, but there are also others. Polygenic will be inflammatory bowel disease. But it is important to know that according to the more recent statistics published by the London group, there is a steadily increasing percentage of patients diagnosed with AA where we actually cannot identify the underlying driver of the chronic inflammatory response, okay? And these patients may have some yet unknown errors of inflammatory response. You know the story of the FMF, right? There was a founder mutation, and here we are in the countries around the Mediterranean basis, right? The other group of patients where we see more AA amyloidosis are patients who have chronic infections due to IV drug use. And more recently, obesity has been identified as a susceptibility factor. Okay? In general, the story with AA and let's say patients with inflammatory arthritis is that people with chronic process tend to develop AA, but not everybody with the same history will develop AA. So there is something else going on, maybe some genetic predisposition. But among the same patients, skinny persons have less chance of developing AA than obese patients. So we'll probably hear more about obesity as a susceptibility factor in the future, given the way we all have our love affair with food, especially here, right? Okay, so keep this in mind. With this, I am moving to the third condition, ALEC2, amyloidosis derived from leukocyte chemotactic factor 2. It all started in the southwest US, okay? And there is clearly association with Mexican-American ethnicity. Etiology is unknown. The genetics is not fully understood. There is, importantly, no effective treatment. Hence, when you diagnose it, keep this in mind. Okay, and do not misdiagnose it as AL. Interestingly, the first reports emphasized interstitial deposition of amyloid and patients presenting with slowly progressing renal failure, but as more cases are being looked at, there are also cases with glomerular involvement. Okay, and interestingly enough, incidence of ALEC2 within the US is markedly different. Overall, it's the third type of systemic amyloidosis as affecting the kidney. But if you look at the southwest US, ALEC2 actually is more common than AL. Okay, so here we have US. ALEC2 has been also reported from Canada, from the First Nation people. There is a big study from Egypt in collaboration with the Arcana Labs where ALEC2 was shown to affect 31% of patients, more often than AL, second to AA. Patients with ALEC2 are reported from Indian subcontinent. There is one report from China. But as far as I know, no patients who are Caucasian Europeans have been diagnosed with ALEC2 thus far, okay? So there are some interesting associations. I will not go into further detail. And then with this, we are moving on to hereditary amyloidosis. So previously I was talking about familial AA, where you had some defects, some mutations in proteins involved in channeling of the immune response, but the amyloidogenic protein itself was not mutated. Here, in contrast, in hereditary amyloidosis, we have mutations in the amyloid protein. The most common is amyloid derived from fibrinogen, transthyretin, but also others. And it is important to keep in mind that although individually these are rare, collectively they contribute about 10%. So something what you have to keep at the back of your mind, especially if your workup shows something which makes you less comfortable with the diagnosis. Typically, AFib, fibrinogen amyloidosis, is said to be associated with Northern Europe. The reports are coming mainly from London Amyloidosis Center, and also here close to home from Portugal, Dr. Tavares, Dr. Roberto et al. This is a typical image of fibrinogen amyloidosis. Phenotype is variable, but renal involvement drives the clinical image, and family history is frequently missing. And here again, do not misdiagnose it as AL. And I've seen patients who received chemotherapy under wrong diagnosis of AL, okay, which is obviously detrimental. I'll talk about treatment in a moment. Very briefly, hereditary ATTR, which is amyloid derived from transthyretin. As you know, transthyretin, the same as fibrinogen, is produced exclusively by the liver. Transthyretin is predominantly produced by the liver, greater than 95%. Other sites include choroid plexus and the eye. It's involved in transport of thyroxine and retinol, and it circulates as a tetramer, as shown here. And the protein itself has only 126 amino acids, but there are over 100 mutations, so there is a great variability. But the most common phenotypes are that of cardiopathic or polyneuropathy. Gastrointestinal involvement is common. Kidney involvement is, at least to some extent, dependent on the mutation. Okay, and interestingly, this is a reference, even within the same mutation, there are phenotypic differences, for example, in patients from Portugal versus patients from northern Sweden, and even from the same geographic area, depending on the fibril making up amyloid, their phenotype may be different. Importantly, penetrance is highly variable, such that many patients develop symptoms late in their life, and hence family history is often missing, and again can mimic light chain amyloidosis, and there is danger of misdiagnosis. Okay. And this is distribution of transthyretin amyloidosis. Okay, transthyretin amyloidosis is the most common in the US, in North America. It's actually all started with founder in Portugal, then there was another hotspot in Japan, and subsequently in northern Sweden, but there is also a significant number of patients in Brazil, and there is worldwide distribution. Depicted as red is mutation V30MET. In the US, we have a mutation V122, which has association with African American ancestry, and the founder has been traced to Western America. In the UK, there is ALA60, different mutations. So the message which I want to convey is that the phenotype can be different, and you can encounter clinically significant involvement in transthyretin amyloidosis. What about treatment? I mentioned that transthyretin, fibrinogen, and other proteins which may be associated with systemic amyloidosis are produced either exclusively or predominantly by the liver. So first there was liver transplantation as a form of surgical gene therapy. Now there are new developments, clinical trials, and actually some drugs already in testing. One group of drugs are TTR tetramer stabilizers. I mentioned that transthyretin circulates as a tetramer, and the presence of a mutant destabilizes the tetramer. And those monomers circulating have tendency to congregate and form fibrils. So tafamidis, already approved by the European Union, is used clinically as a stabilizer. Other off-label use involves diflunisal. More novel drugs are those which involve TTR gene silencing, as well as antibodies against misfolded transthyretin monomers. And the issues which are associated with this are listed here.
Maria, can we conclude in a few slides?
Okay. You want me now? Or can I show you the slides?
No, a few slides will be okay.
Yes, okay. So with renal amyloidosis, light chain most commonly, but not only, as shown here. Be prepared that you may encounter zebra, okay? I wanted to show Congo red is still the gold standard. It's not all green apples. Apples are maturing. We are approaching fall, so yellow and orange are also diagnostic, and it all depends on the angle between the fibril and your polarizer, okay? And this is, explained here. And I want to finish with the appeal that please, we need to change our approach to diagnosis of amyloidosis. Every time I see images like these, I have the feel that this is our failure at the clinical level, pathology, because at this stage, treatments are not going to alter renal function. But we need to actively look for amyloid when we have a biopsy with essentially normal glomerulus, what was brought up earlier during the electron microscopy. And these are kidneys with a relatively early amyloid, PAS stain. There is a minute area with mesangial expansion here, silver stain. And what I want to conclude with, think about amyloid and order Congo red stain. We do all these stains, okay? But please order stain. It's not correct entirely that you need thick sections. Yes, thicker section will help you to detect amyloid. But if you don't have thicker sections, you may stain 2 sections at the beginning of your ribbon and at the end of your ribbon. And what you need is a good optics, okay? And then you can increase sensitivity by looking at this Congo red stain slides under fluorescence and stuff. So with this, I'll end. Thank you.
Thank you, Maria, and thank you for keeping the time. We have time for 2 questions. Yes.
Okay, Joanna, Maria, what about mass spectrometry? Do we need to do on all cases mass spectrometry?
No, and Sami has published, there is published literature on the subject. If you are sure that you're, especially if you are working with frozen sections, if you have a clear cut, I lost it, light chain restriction, that you are sure, okay, everything fits, by all means, go for it. But if you don't have tissue for fluorescence in frozen sections, be very careful, because immunohistochemistry in paraffin, you are facing many issues, one of which is the fact that you have a background stain from the serum proteins, okay? I mean, amyloid typing is essentially light chain versus everything else. Okay, and 85% is going to be light chain, but not all light chains will show you clear-cut light chain restriction. And cases where I am not satisfied, I go ahead and do other studies. That's very important. Okay, you cannot take chances with light chain diagnosis because of the clinical implications. Okay.
Great, thank you. Is there another question? Yes.
Thank you, Maria, for your standing presentation. Well, actually, I don't know if the question is useful now because you should just show it in your last slide. I was going to ask about what was talked about previously about the protocol of stain sections. If you recommended actually to always include a Congo red thick section in all renal biopsies?
No, not really, not really. I mean, amyloid is irregularly distributed, so the thicker the section, the greater the chance of picking up amyloid, okay? But I routinely use my unstained slides because, you know, we all do the same thing. We cut several slides and we save in between. So rather than me trying to cut thick section at the end, I do 2 slides, right? At the beginning and at the end. And if you want to increase sensitivity of Congo red stain, use this which is shown here. This is from the blog which I've written for American Journal of Kidney Disease. And you can see here Congo red and bright light, which is not diagnostic. This is under polarized light. You have these issues of polarization, shadow, etc., which I'm discussing here. And then if you just use fluorescence light and look at the same slide with fluorescence light, you can localize even smaller deposits. So whatever works for you, use everything, but do Congo red stain, okay?
Thank you, Maria. That's a very nice tip. I always did that with the iron. Thank you so much, Maria.